Virginians who care about healthcare. Welcome to our joint oversight subcommittee. I don't have any excuses for my fellow delegates, but it's always an honor to be here with all these substantial senators over here that are movers and shakers. And if there's any new people here that don't know how this joint subcommittee works, you're just like us. But I was telling Senator Deeds a minute ago, I think it's should be the most important thing that I do anyway, is to make sure we're spending our money the best way and improving as many lives as possible. And the way the chairmanship of this thing works, it was the House's turn. That's why I'm talking right now. And next year there'll be a senator. Next year there'll be a senator with the automatic gavel. He already pressed the automatic gavel button. He can't wait for next year. That was a joke. So anyway, welcome. And we have, our agenda's not too long, but it's really important. And the first topic is something we all hear about a lot, and many of us have parents that are need this service, or cousins or relatives, or have been through it already. And it's we're going to talk about long-term care insurance in Virginia. So, do we need to do introductions or take the roll? Is there any opinions, council? No. Everybody know everybody up here? Everybody knows everybody. I think everybody knows everybody. Yeah. You want to Wait, go ahead. Well, there's only 5 of us here.
Good morning. I'm Senator Barbara Favola, and I represent the 40th Senate District. It is entirely contained within Arlington County.
Senator Reeves, I represent the 28th District, which is the counties of Spotsylvania, Culpeper, Orange, Madison, Greene, Rappahannock, and Fauquier County.
Adam Eben, representing the 39th Senate District, which includes parts of Arlington, all of Alexandria, and part of Fairfax.
My name's Creed Dietz, and I think it would be fun to tell you about all the counties, all the localities I've represented over the last number of years, but I'm not going to do that. I represent the 11th District.
I'm Mark Sickles, and I represent a portion of Southern Fairfax County, the 17th District, as it's currently configured. So, Ms. Allen, please come forward, the Chief of the Bureau of Insurance Policy Analysis, to talk to us about long-term care in Virginia. Welcome.
Chairman mentioned, my name is Rebecca Allen. I'm the Chief Policy Advisor for the Bureau of Insurance. Oh, sorry. My name is Rebecca Allen. I am the Chief Policy Advisor for the Bureau of Insurance, here to talk to you today about long-term care insurance in Virginia. So from the outset, let's just establish what long-term care insurance is and is not. It is not health insurance. It's really intended to help consumers live as they live now, instead of improving or correcting medical problems they may have. Most of the time when I think the public thinks of long-term care, they are thinking of the nursing home setting, but long-term care insurance can cover care outside of those settings. It can happen in their home, in a adult daycare center, assisted living, and the care that is being provided can be assistance with activities of daily living, ADLs, it can be home care, it can be adult daycare. There's a wide spectrum of what long-term care insurance can cover and the settings in which it can be provided. And as I'm sure the members of this committee know, Medicare generally doesn't pay for personal care services if the consumer isn't also receiving Medicare-covered skilled services. So if there's a need for the personal care, they can't tap Medicare to do that. So long-term care insurance can cover that gap. For long-term care insurance, you can get it in a number of places. So there is, of course, the individual long-term care insurance policies that you individually go out and get. There's also group long-term care insurance policies or individual policies that have a group discount. You'll most often see these being offered by associations to their members or employers to their employees. I will note that if you do have a group long-term care insurance policy, or you have one that has a group discount, an individual one with a group discount through your employer, if you happen to leave that job, you're terminated, or the employer opts to discontinue that as a benefit, the insurance company cannot end your coverage purely on the basis of that loss of that job or the ending of the employer's participation. They can, of course, adjust your premiums and your benefits if that were to be the case, and you may not be able, with that premium and or benefit change, either be interested or be able to afford coverage, but just because the job piece has ended doesn't mean that they can kick you off of the policy. There's also the Federal Long-Term Care Insurance Program that is limited eligibility, so federal and U.S. Postal Service employees, members, retired members of the uniformed services, and of course qualified relatives. There is also, we are seeing here in Virginia and in other states as well, the life insurance policies and annuity contracts being leveraged to pay for long-term care services. So with a cash value life insurance policy, it could allow for a taking of a portion of that value to pay for a number of expenses, including long-term care expenses. Unless the policy has a specific rider on it, a long-term care rider on it, the life insurance company can't market it specifically for long-term care expense coverage, but just know that if your policy allows you to take some of that cash value, that you could potentially use it for long-term care expenses in addition to a wide range of other expenses that you could leverage it for. Same thing with annuities. You may take some of its value, again, to pay for those long-term care expenses. If you do that, on the long-term care side, on the life insurance side, it could reduce your death benefits. On the annuity side, you may have to pay a surrender charge for that. I did touch on the long-term care rider. Now, this is specifically marketed to pay for long-term care expenses. You will sometimes see in consumer literature that is broader than Virginia's. You may see it called an extension of benefits rider, but here in Virginia, it's a long-term care rider. It increases the policyholder coverage beyond what the cash value or death benefit would be. And as you probably could guess, the more riders that you add to the policy, the more the premiums would go up. That is the broad universe of long-term care insurance policies. Within that broad universe, there are tax-qualified long-term care insurance policies. If they're federally tax-qualified, taxpayers can deduct the premiums subject to a cap. The benefits generally aren't going to be considered income on their taxes. And for the policies that are sold after January 1st, 1997, they have to be guaranteed renewable, and they can cover only qualified long-term care services. If it's not tax qualified, then the opposite's true. You cannot deduct those premiums from your taxes. The benefits you receive are going to be counted as income. The qualified long-term care services piece of it, a policyholder has to be chronically ill in that they either cannot do at least 2 of 6 ADLs without substantial assistance for at least 90 days, or they have a cognitive impairment and they need substantial supervision. And the care that they're getting must follow a plan that a licensed healthcare practitioner has prescribed for them. Going back to that life insurance and that annuity piece, if they have that long-term care rider on them, those riders could be tax qualified as well. So you could enjoy some of the benefits of the deduction of the premium and discounting the benefits as income, but it wouldn't be the entire portion of the benefits you receive and the entire portion of the premiums. It would just be those portions that are attributable to the long-term care component of it.
Mr. Chairman.
Senator Reeves.
Rebecca,
Yes.
are the tax-qualified insurance policies, are they required to add restoration of benefits after, let's say you have an individual and they can't do 2 of 6 activities of daily living, but they get better. So they're no longer having to have those issues. They're back to restored. Are those policies required to restore the benefits back to what they originally were?
Mr. Chairman, Senator Reeves, I will defer to some of our subject matter experts who have joined me in the audience today. I have Julie Fairbanks and Julie Blauvelt.
We don't have to take up committee's time now, but I'd like to answer that question maybe when we get done. Thank you.
That's fine. So that's the wide universe. We've narrowed it down to tax qualified. Now we are narrowing it even further to partnership policies. So in 2005, the feds passed a Deficit Reduction Act that gave states the option to create partnership programs. These are public-private arrangements between the state Medicaid agency, in Virginia that would be DMAS, and private insurance companies. These were originally piloted by 4 states. California is one of them, and also Indiana. And they were so successful, the feds decided to expand that and give that option to all states. Amendments were made to the Code of Virginia, specifically 32.1-325, sub B, sub 24, that does direct DMAS to include as part of the Virginia's state Medicaid plan the authority to establish that, to have that partnership program here in Virginia, and those policies are available. So if a consumer does purchase these policies, the thing that makes these special is not only are they tax qualified, but they also help protect assets in case a consumer will later need the state to help pay for long-term care through Medicaid. So the exact amount of assets that is protected is dollar for dollar the amount that the policy has paid out. So normally there are asset and income limits in order to qualify for Medicaid. I believe the current asset limit's $2,000 if we're talking to a single person. It goes up if you've got a married couple with either or both applying for Medicaid. But so it's $2,000. So that means if you've got assets in excess of $2,000, you must spend down to get underneath that limit. The partnership policies allow you to insulate more assets. So if you have a policy, it has paid out $100,000 in long-term care benefits, that means you get to protect $100,000 worth of assets plus the $2,000, so $102,000 in total. So that's the benefit really of that, that partnership policy. Another piece of it that's important to note is that the spend down that I mentioned, you got to get under those income and asset limits, that's just to receive Medicaid. Once a Medicaid recipient has died, there is something called the Medicaid Estate Recovery Program. The assets that were under that limit are no longer protected. The state has an obligation to go after those assets and try to recover some of the costs that they have put out under the Medicaid program. If you have one of these partnership policies, you could potentially protect even your home from the Medicaid Asset Recovery Program. So there are some benefits to it beyond just the spend down. You can also insulate additional, or not additional, but you can, as part of your, I've got a $100,000 payout, dollar for dollar, I want to protect $100,000 of my asset. It doesn't have to be cash. It could be property as well, like real property. They also have to include inflation protection benefits. Depending on what age you were when you bought the policy, you are either going to be getting compound annual inflation protection, or you're going to be getting another level of inflation protection that's basically lesser than the compound annual inflation. But that's what how the partnership policies work. So you've got all the long-term care insurance, you've got the tax qualified ones, and then you have the partnership ones that have the asset protection piece of it and also the tax qualification piece of it. And at the prior joint subcommittee meeting, I know there was questions about prior consumer outreach about long-term care insurance policies here in the Commonwealth, specifically an effort that had been made some years ago to really promote the uptake of long-term care insurance. I will say that on an ongoing basis, the Bureau of Insurance has consumer outreach efforts. We have resources available on our website. We have folks who go out to different community events to talk to them about all types of insurance, not just long-term care insurance. So I don't want, when I present this to you, think this is the only thing that has happened in the Commonwealth and we haven't done anything since. With that being said, in 2005, there was a joint federal and state initiative called the Own Your Future Awareness Campaign, and it was targeted at retirees and near retirees to really push long-term care insurance, to educate them about what their options were, of course, to educate them on what Medicare does and does not cover. Those campaign materials included a letter from the governor of the participating states and a trifold brochure that had a little tear-out postcard in the back that folks could send in to receive a long-term care planning kit. There were TV and radio spots prepared. There was also follow-up postcards that went out to remind consumers, hey, if you want this planning kit, go ahead and ask for it. It's absolutely free. And of course, the planning kit itself, which featured a 28-page brochure and perhaps in a nod to the times in 2005, an audio CD with interviews of persons engaging in different types of long-term care planning activities. There was also a toll-free number that was operated by the campaign. So if you didn't want to mail in the card or you lost the card to ask for the planning kit, you could call the number and have it sent to you that way as well. So the target response rate for that program was 5%. There was a phased rollout. Virginia was in the very first phase. The core campaign components that I've laid out here, those were supported by state-specific efforts. And then, of course, after the long-term care, after the phase one ended, the planning kit was published online. I will note that consumer-focused website is defunct. It's been about 20 years, so they have not maintained it. I know. I know there was also questions at the prior meeting about what the outcome of that was. So as I mentioned, the target response rate was 5% for all of these mailings and outreach. And I'm going to show you the phase 1 campaign, since that's the part that Virginia was a part of. So as you can see here on the screen, I've highlighted in yellow for you the Virginia line. We sent out the second highest number of direct mail mailings, 630,000. Those went out in January. Our governor, then Governor Mark Warner, did a press event contemporaneous with that. We only did TV spots here in Virginia, and we only did them in selective markets. Though I will note that the selective markets that were targeted in 2005 would have captured about 66% of the population here in Virginia. We did the follow-up postcard in March. The number of toolkits that were requested, we were, again, the second highest at 65,189. And our response rate was the best of all the states in phase 1, 9.1% response rate. And you can see on the screen as well what the cost was per that response, and we had the second lowest cost per response. I will note that the cost that's on the screen does not include the call center cost, the fulfillment center cost to send out those planning kits, or the development, testing, creation of all those campaigns. It does include the printing costs, but just not the design piece of it. So with that being said, there's also the state-specific part that I touched on. In Virginia, Governor Warner, for the TV spots, had done a personal introductory message to be included with them. There was also outreach to all state government employees around Valentine's Day to encourage them, of course, to get that kit, and of course, to remind them of the benefits, long-term care benefits that they have as state employees. Though we did not do radio spots here in Virginia like other states did, there was some outreach via the radio. There was an interview done with an HHS assistant secretary, and then about a week or two later, Governor Warner went on that same radio station, a local show that they had about Your Legacy, Your Life, to also talk about long-term planning needs. So there was radio outreach. It just wasn't the specific radio spot that had been put together.
I have a question. Since we did this, did the private sector pick up the marketing efforts? We haven't done it in 18 years or 19 years. Are they marketing themselves adequately to sell policies today?
Mr. Chairman, I'm not sure that I am able to gauge the effectiveness of the outreach and marketing that the long-term care insurance companies are doing. I'm sure that they are putting as much resources as they can, because they want to be able to sell the product. But to the effectiveness of it, I could not answer.
I mean, isn't it? I mean, it's kind of everybody believes that not enough people have long-term care insurance, right? That's a problem. It would be better for society if everybody had long-term care insurance, but nobody's really pushing it. Is that fair to say?
Mr. Chairman, I don't know that I could say that's fair to say. I'm not sure. In terms of the reason they do not have it is because there's not sufficient marketing. There may be other concerns that are preventing consumers from purchasing these policies and then continuing to pay premiums. Cost and affordability is a concern for consumers, so that may not be able to overcome even the best marketing.
Understand. Okay, thank you.
Yes. I also note that the state aging networks, the area agencies on
Senator
agency.
Favola
Oh,
has
I'm
a
so sorry.
question.
Thank you, Mr. Chairman. It's sort of related. When I delved into this during the 2005 campaign, one of the marketing points was if you took long-term care insurance when you were younger. Now, I guess younger defined as being under the age of 40. The premiums, of course, were much less. The expectation was you weren't going to collect on it for 20 years. So maybe we were sort of marketing, not the state necessarily, but we, the collective, we could be marketing to the wrong cohort. I mean, if you start marketing to folks who may need long-term care insurance in the next 10 years, costs would be a factor. Is that correct?
Mr. Chairman, Senator Favola, it is, from the information that I had about this specific campaign, the average consumer that was reached, the average age of the consumer that was reached was age 59. Now, that's for the entire campaign. It's not specific to Virginia. I don't have the breakdown to that level. But to your point, if you're wanting to target much younger cohort, then this campaign, on average, skewed higher because it was aimed at retirees and near retirees.
Yourself? Who are you?
I'm the new senator from the 2nd Senate District, Mark Obenshain. It's nice to meet you all.
Thank you for joining us today. I'm holding up the fort on this side. We need $300. Okay.
No, Mr. Chair, I would say that we take this responsibility seriously, in contrast to others.
Okay. Well, some of our members are recovering from surgery, okay? I'm not going to mention who that is, but I'm sorry about this interlude here. But we're trying to be kind to Senator Obenshain. Okay, please continue.
Of course.
With all this good news.
Yes. So the state aging networks, the area agencies on aging, hosted information booths at local fairs and festivals, and the Department for the Aging, which is what it was called back in 2005. They were not yet DARS. They also did several educational presentations at local community and nonprofits. So that's the efforts that Virginia specifically did in addition to the core campaign activities. In talking with DARS about this, which I will give them credit, they had a lot of this information, they had maintained it, so I was very grateful since it is about 20 years old. In talking with them, it looked like around that same time in 2005, 2006, there had been budget amendments proposed that would have put money into the budget, about $50,000 for additional awareness campaign activities, but those budget proposals were ultimately unsuccessful and we weren't able to locate anything too recent in time specific to that. Certainly nothing that had been successful. Moving on to the long-term care piece, specifically here in Virginia. So this is going to be a combination of data that the Bureau already had and also a survey that we conducted of the companies that were currently marketing long-term care insurance in 2023. So as you can see here, we have put on the screen the partnership versus non-long-term care partnership policies in the Commonwealth. So overall, in the last 5 years, there is slightly more than half that are non-partnership. That doesn't mean they're necessarily not tax qualified. They just don't have that partnership component that has the asset protection piece for Medicaid. And you can see, breaking it down year by year, that the number of partnership policies that are being issued is going down over time. So in 2020, just shy of 40% of them were partnership qualified, or sorry, just shy of 40% of them were not partnership qualified. Now in 2024, you're looking at close to 70% of them that are being issued, not enforced, but that are being issued every year are not partnership qualified. In terms of what is issued and enforced, these are the excuse me. These are the ones that are enforced at year's end. So you can see that there's been a slight decrease over time, not a big one, but we are seeing a slight downward trend in the standalone policies that are enforced at year's end. We're not sure if that trend is going to continue or if it's going to bump back up, because as you can see in 2021, it did tick up a little bit before starting to head back down again. So we're not sure if this is just, we're looking at some pandemic-related issues, some economic issues that are short-term in nature, or we're going to continue to see a trend, even if it's slight, in a downward direction for the long-term care insurance policies. Now, these are the standalone policies. There are also, as I mentioned, the life insurance policies and the annuities that have the long-term care riders on them. Now, for those, we are seeing an uptick, certainly on the life insurance side, in the ones that are being issued that have that long-term care rider on them. And there's more companies that are offering those. So there's, I said there's 10 that offered long-term care insurance in 2023. As you can see, we've got nearly double that on the life insurance side. Companies offering those.
Rebecca, is it not mandated reporting from the insurance companies to say what the lapse was caused from, the lapse or cancellations? They don't have to report that? So that's how we don't have that data? Because it'd be really interesting to know if it was based on on price, and they're getting to the point where they can't afford it because other things are becoming primary, right? I mean, you're selling a non-tangible with long-term care till you need it. So it's like life insurance. But I'm just curious, that would be important to note it, if we can get it.
Mr. Chairman, Senator Reeves, that's going to be one that I'm going to throw to our subject matter experts. Would you like that to be answered now?
Well,
or-
we'll hold that to the end, too.
Okay.
I've got 2 of those now. Thank you.
As I was saying, you can see that there is an upward trend on the life insurance side. On the annuity side, it's not as clear of a trend upward. There was certainly a drop-off from 2020 to 2022, but it's starting to perk back up in 2023. Though we do have fewer companies, I will note, that are issuing those types of annuity policies that have that rider on them, or annuity contracts with those riders on them. And there's an upward trend. Now, I will note, if you recall from the slide that I was showing you, the overall long-term care insurance policies in force, we were looking at 140,000, whereas here you're looking at 40,000-ish on the long-term care insurance side, or sorry, on the life insurance side, and you're looking at just shy of 2,000 on the annuity side. So in terms of scale, it's not as big, but it is going upwards, and we are, like I said, seeing a slight downward tick on the long-term care insurance side. And this chart here summarizes the year-over-year percentage change that we're seeing between the standalone long-term care insurance policies, the life policies with long-term care riders, and the annuity contracts with long-term care riders. The long-term care riders are more popular. And we've also provided for you all the companies that have in-force business, standalone life and annuity. There's still more companies that have policies in force on the long-term care side than on our annuity and life insurance side. But this is the in-force business. If you flip it and start looking at the issuance, it's going the other way. Like I said, there's only 2 companies that are doing these annuities, so that number is not moving too much, but the life insurance and the standalone long-term care insurance flips if you look at the new issues versus the ones that are in force in total. All right. Turning to efforts in other states, this is not going to be a comprehensive deep dive because there was not enough time. So I'm not going to touch on legislation that has been filed that has not either been successful or has not, we don't know what the final disposition of it is. Instead, what we're going to focus on in this section is what other states have done either in terms of studies or in terms of programs that they have enacted. So right out the gate, Washington, they are the furthest along the pathway in terms of coming up with solutions for long-term care insurance. They have created a public long-term care insurance program in Washington, the WA Cares Fund. All working Washingtonians, subject to some exemptions, contribute via payroll deductions a small percentage of their income into the fund. And then when care is needed, of course, they can access their earned benefit to pay for those long-term care long-term care services, excuse me. Currently, the payroll deductions are 0.58%. Those began last July. I will note right now on the ballot in Washington, there is an initiative to have the voters decide whether they should continue to be mandatory or if it should, I'm sorry.
Senator Deeds has
This
a question.
Washington State now.
It is Washington State.
Yeah, okay, thank you.
Whether it should be continue to be mandatory or if it should flip to voluntary. Now, depending on the outcome of that vote, if it does swing to a voluntary payroll deduction, that's obviously going to have major implications for the program design and its solvency. So remains to be seen what the ultimate fate of this particular program is. But as it stands now, the full benefit that a person could access under this program is $36,500, which will adjust upward for inflation. And you can get that full benefit in one of 2 ways. Either you have contributed for 10 years or you've contributed for the last 3 out of 6 years and you have a sudden need for care due to injury, illness, or disability. And to Senator Favola's earlier point about, well, maybe folks are being targeted and it's a little too late for them to be able to save or purchase at a reasonable rate. The state of Washington did recognize, well, if you're born before 1968, you might run into a problem being able to qualify for that full benefit because you just don't have enough work runway. So they did create a partial benefit pathway that's equal to 10% of each year contributed for anyone that was born before 1968. So they don't get the full benefit, but they do get some benefit. And the benefits are now portable. That was a later change that they made to it. So if you are a Washingtonian and you decide to move to Idaho to retire and you need long-term care services in Idaho, the Washington Cares Fund would pay for it, if you, of course, qualified. Automatically exempt from the fund are going to be federal employees, tribal employees whose tribes aren't participating, the self-employed, and of course those who aren't working either because they're not working or they are retired. There's also voluntary exemptions available. Folks who are not permanent residents of Washington, if they're temp workers on a non-immigrant visa, if they're the spouses or domestic partners of active duty military, and veterans who have 70% or higher service-connected disabilities. I will also note that this long-term care insurance program came about after Washington enacted paid family leave. So that program came first, and then this program followed, just so that we have the order of events here. Moving to California, they had done a study. They published their feasibility study in 2022, followed a year later by an actuarial analysis, and they were looking at what are the options for a public long-term care insurance program. And if the members of this joint subcommittee are interested in seeing the feasibility study and the actuarial analysis, we of course can provide that. It's lengthy, and I tried to condense as much as I could for you here. So they came up with a number of different program designs. So this is the general across all of them, unless otherwise noted. So 2 out of the 6 ADLs or severe cognitive impairment eligibility criteria, just like what you saw for the tax-qualified long-term care insurance policies. Depending on how they do the vesting, if it's a 5-year vesting period, you can get partial vesting after 3. If it's a 10-year vesting period, you get partial vesting after 5. There's reimbursement benefits in all the designs and a 50% cash alternative in 3 of the designs that they came up with. And of course, there is benefit inflation protection. They pegged that to the CPI. On the financing side of it, they came up with a couple of different ways: a progressive payroll tax, a contribution cap, indexed with inflation, a contribution waiver in all the designs. And then contribution rates, they split them 50-50 between employers and employees. My understanding on the Washington program that we just talked about, that's coming straight from the employee's paycheck. There's no employer contribution on that one. And then they also tackled the issue of private long-term care insurance. They talked about the payer order. So if you happen to already have private long-term care insurance, your private long-term care insurance would pay first, followed by this hypothetical public long-term care insurance program, and then Medicaid at the end. For those who already had a policy, they decided to suggest an opt-out. So if you have eligible coverage, and they did not define what eligible coverage is, so I cannot answer that question, but if you had eligible coverage, you either could opt out entirely if you had that coverage before the effective date, and if you got it after the effective date, they would reduce how much you would have to pay into the fund. And that would, if you had that eligible coverage, they would require recurring certification that you have maintained that coverage. So you don't have someone buy the policy and then let it lapse to avoid either all or part of the contributions. And then the work group could not, they ran out of time essentially to get to the idea of supplemental private insurance options, so they recommended an additional work group to tackle those things. No legislation has resulted yet from the work that California has done on this. But they, like I said, they came up with a number of designs. We are happy to provide that information to the Joint Subcommittee if they would like to look at it. I condensed it down to one slide, so there's quite a bit more information than just what I've presented here. There's also Minnesota. So Minnesota did a study in 2023. Theirs was broader than just the long-term care insurance program. It was about increasing access overall to long-term care insurance financing services and supports. They rated their options on the criteria that you can see here on the screen, and they came up with 3 overarching options. One was a care and navigation support option to reach out to the folks who may need to be leveraging this care, may need the support, may need information on the financing. So having a portal, online portal that was specifically directed to them so they could figure it out themselves. Enhancing their existing telephonic support for those who either need the additional assistance or because of broadband issues, they have to do it by telephone, and then in-person support. And they debated whether or not that should be paid for by the state or if there was going to be a charge for those who could afford to pay for it. They also talked about a Medicare companion product, and there's 2 approaches that they talked about: a market-driven approach and a compulsory approach. And then, of course, they had the catastrophic light benefit program. So this one's going to look similar to what we were seeing in Washington and what California has been kicking around. I will say this study that Minnesota did, this was done by one of their executive branch agencies. It's not a perfect one-to-one to Virginia, so it's roughly their equivalent of the Department of Health and also the Department of Social Services and also a little bit of Medicaid. That's the executive branch agency that did this study. We are anticipating another study out of Minnesota in January, and that's going to be from their Legislative Task Force on Aging. It's going to be talking about long-term care insurance. We just don't know specifically what they're diving into. So as soon as we have that information in January, happy to share that. And of course, we can share this study with you all as well. It's a fun 127 pages.
Senator Favola.
Thank you. I think these examples are pretty interesting. I'm just curious, I don't know if you were able to delve into the politics or the culture of the various states at the time these options were put before them. Was there pushback from the business community? Were all employers required to offer this to employees, or were the employers that had a certain size?
Mr. Chairman, Senator Favola, I'm assuming you're talking about the Washington option?
Yes, I am.
So my understanding from this, I'm not sure about the political composition. We can provide that information to you, but it's all working Washingtonians minus the exemptions that you see on the screen. So the
Senator Favola.
Oh, thank you, Mr. Chairman. Sorry. So the part-time waitress who is working 20 hours a week, still in college, is on the payroll of this restaurant. Is she contributing?
Mr. Chairman, Senator Favola, I would have to go back and double check on that, but I did not see in the preliminary information that we pulled together that there was a specific exemption for the part-timers.
This really is comprehensive. Thank you, Mr. Chairman.
I've got one. I think I've got a question. In advocating for a public program like this, to what degree are Medicaid savings proposed? Is that an objective of this? Because Medicaid is becoming more expensive. We're aging society. On these, long-term care is in the future for many of us, and not that far away, maybe. And so, is there an argument? What's the public policy argument for having this, other than a humanity argument? Maybe you get better care if you have long-term care insurance. I don't know about that, but how about just saving money in their Medicaid program?
Mr. Chairman, I know specifically in the Minnesota example, that is something that they were rating these options on, was a component they were rating it on, is the impact to state Medicaid. That is part of the cost and efficiency calculus that they did. And some of these measures are qualitative, some of them are quantitative, and that was one thing that they were looking at specifically in Minnesota. As for California and Washington, I would have to go back and look to confirm that's what one of the considerations were, but I would be surprised if that wasn't something that was debated.
And to follow up, the Medicaid programs in those states now is viewed by the advocates of these programs as being inadequate. Would that be a fair statement?
Mr. Chairman, without having spoken to the advocates for this program, I don't know that I could speak for them.
Yeah, okay. All right. Well, any further questions? Senator Reeves, you have questions, I know.
Yeah, if you can have your other person come up, that'd be great.
Thank you, Ms. Allen. That was really interesting.
Yeah, it was.
Hi.
Hi.
Good morning.
Morning.
I'm just going to run through these and maybe you can hit them off. I don't know what the current look back for Medicaid is for assets and for an individual. Is it 3 years now or is it 5 years?
I'm not sure I have the answer to that question.
In other words, in order to go on a Medicaid, you've got to be down to $2,000 now, but what's the look back? So especially for these attorneys that are in here, I'd be curious what the look back is.
Mr. Chairman, Senator Reeves, my understanding is the look-back period is 5 years, but DMAS would be in a better position to confirm that.
Okay. And then my other question, second question is, what's the average stay now for those folks that are doing 2 activities a day living in a long-term care facility? Is it 3 years, 5 years? Has it grown since 2005? Do we have that information at all?
Mr. Chairman, Senator Reeves, we do not have that information at the Bureau. Potentially, DMAS might have that information available that they could pull for you. I don't think they could grab it
Senator
for
Reeves,
you right now.
maybe Steve Ford might have that answer. I don't know if he's testifying today, but Steve, do you know the answer to that? I don't know the answer to that. We could probably do some math. Okay.
The reason I asked, Mr. Chairman, I think as somebody who actually sells these policies, and we haven't gotten an update in quite a long time on it, when you sit down with families and you talk about everybody's health is going to change, and at some point, Mr. Chairman, they're going to have to start spending assets to take care of their loved ones. And all these things that I'm asking kind of boil down to, Mr. Chairman, you asked about what's the need. Well, the need is to protect the assets of the families and to make sure that they're not going to go insolvent trying to take care of one member of a family if it's a husband and wife still alive. And so I think the greater picture as well is we as policymakers have to decide how many folks are going to go in the Medicaid rolls because they didn't plan correctly on what happens. And so this is a lot of information. I have a lot of questions. So that's kind of my logic train and why I'm following it. I'm also curious, you mentioned there were 2 companies that are issuing the policies with regard to life and annuities. I'm curious to who those companies are, why there aren't more companies, bigger companies, getting into it. Is actuarially, is there not enough money for them? And then out of the 2 companies, I'm curious what their Moody's ratings are, just out of curiosity. So, and you can get back to me. I'll give you my number. I'd just like those answers at some point if you guys could get those for me.
Mr. Chairman, Senator Reeves, I don't think it's just, to clarify, I don't think it's just 2 companies that are offering annuities. It's 2 companies that are offering annuities with the long-term care riders. But to your point, we will absolutely get all that
Correct.
information.
I'm trying to understand why there aren't more companies like USAA and State Farm and some of these other bigger entities that are in the life insurance business and annuities business. Why aren't they taking part of it? And there's a risk tolerance there, I think, that the companies are looking at. But if you look at your charts, that sector of that market is growing, and I don't know if it's based on commissions. I don't know until I get the answers. But thank you, Mr. Chairman.
Thank you. Go ahead. Will, please introduce yourself.
Yes. Julie Fairbanks, Chief Insurance Market Examiner with the Bureau of Insurance. Raise it up.
You have a question?
So I was just going to answer some of the questions from Senator Reeves about the restoration of benefits rider. That is an additional rider that can be purchased with a long-term care insurance policy.
And Mr. Chairman, every company that has the partnership policies has to have that? They have to issue that? Or make it available, I would say.
I guess it depends on whether the company offers that as an additional rider that can be purchased, but I don't know whether all long-term care partnership policies have to offer the restoration of benefits rider. I can get that information for you.
Okay. I'd appreciate it. Yeah. Thank you.
Just one last.
Senator Favola.
Thank you, Mr. Chairman. Is it fair to say that to make the long-term care policies robust enough so they cover a range of different services and affordable, the decision was made perhaps in Washington and maybe these other states as well, that you really do have to throw a very broad net. Everybody has to participate, so there's enough resources, if you will, to be able to pool money and mandate, because I expect that private insurance companies are actually carrying the plans that the state is blessing or that the various states believe meet the requirements. But to do that at an affordable rate, what I'm hearing is you need a very broad net. And the mandate actually matters. Is that a fair assessment? Is that a fair takeaway? Because there are clearly some public benefits to this, which I think the chairman pointed out and others. But to get to that public benefit, it's got to be affordable. And I think the mandate's probably what helped the states get there.
Mr. Chairman, Senator Favola, ultimately that will be a policy decision for the General Assembly to make. But with insurance, the more risk or the more people that you have paying in, the more you can spread the risk out. That's a general concept for all insurance, not just this specific. So
The more affordable.
again, that's something that the General Assembly will have to weigh whether that should be mandatory or not.
Isn't it true that the reason these states are looking at this, probably other states, is the long-term care insurance industry is perceived to have failed? I mean, it's not robust like it used to be, and we've had, companies that have been in the business that have kind of stepped back, and maybe they're trying to fix a market defect.
Mr. Chairman, I will, of course, defer if my colleague wants to jump in on this, but with the long-term care insurance product, when it first was out there and being marketed, the actuaries for those companies did the best that they could to come up with the rates and the premiums that needed to be charged based on the best available data then. It turns out that in some cases that best available data didn't allow them to appropriately target to the rates and premiums in order to cover the growing cost of long-term care and how much longer folks are living. So that is a concern that has impacted that specific market.
So follow on that, has apparently with that new knowledge now of the risk that they didn't have when the industry in its infancy, are they doing better in rectifying that, or how attractive is the market right now?
Mr. Chairman, I'm not sure I can really speak to how attractive the market is, but we have definitely seen a decline in the number of insurers that are offering standalone long-term care policies in Virginia. And I do think, as Rebecca mentioned, that affordability is an issue at this point.
Okay.
Mr. Chairman?
Yeah, no.
One question. What's the average daily cost of nursing home care in Virginia? I know different areas are going to have different pricing, but overall average for Virginia, what's the daily cost of nursing home care?
I don't have that information.
Well,
I
there's
would
people
love to
sitting
have
in
that
the
answer.
audience here that might know the answer to that, but, yeah.
Of nursing home care specifically?
Yes, ma'am.
Long-term care facility would be expensive.
No,
We'll get back to you.
I don't want to put people on the spot again, so.
Put them on the spot.
Put them on the spot, well, okay.
Mr. Chair.
Senator Oberchain.
According to my detailed research, it's $10,496 per year for a private room in Virginia.
Year per
That
month.
Can't be right.
That can't be
month.
right. That's per month.
Per month, the monthly cost, that's right.
Yeah, okay. So that's hence the problem. So the premium, what we have here is to cover the cost of a good skilled nursing, the premiums for this product have to be relatively high, and there's no mandate to buy it. So it's, that's the problem. It's and I do think, are you trying to escape? Okay, come on down. And please introduce yourself. We have a wide TV audience all across the Commonwealth this morning.
Steve Ford with VCA VCAL. So we don't collect the data on the private pay rate, which is often very different, but Medicaid is the primary payer of long-term care in Virginia. I think the Medicaid, it's hard to know the average rate because we pay based on acuity. And we at the association don't know the actual acuity distribution in a given period until later on. But as an estimate, I would estimate about $250 to $275 a day is the average Medicaid rate. As you all have heard us talk about before, that doesn't cover the cost of care for every facility in the state of Virginia. So the private pay rate is going to likely be higher than that average across the board. And Senator Obenchain quoted a number that if you do the math at 250, that doesn't hit his number. So that's probably the difference you're looking at there. You're looking at between $90,000 to $120,000 a year in that range that we've just presented. So
The industry has a strong interest in this market. I mean, you don't have anything to do with it, but if we had more people with long-term care insurance, it would be better for our skilled nursing industry for sure, correct? That's pretty simple.
I'm not a long-term care insurance expert, but usually those, you guys correct me if I'm wrong, those policies typically have a daily limit on what they pay, and that limit may not be the cost of care. Is that not correct?
Yes, it's a different.
So there's typically a delta there. Yes, I mean, it's another payer. It's another payer towards the cost of care.
Right.
So the Medicaid program would definitely benefit. The state would definitely benefit, but it's a tough question for the nursing facility because it's just another payer in the mix of payers.
So, I mean, most patients will have their Social Security check, maybe some retirement, maybe some savings, and they don't have too much savings because you got to be down to $2,000 to qualify in Virginia. But those three sources combined will pay the monthly rate.
Yes, and I think you all know this. The Medicaid program pays the rate minus their Social Security check, that sort of thing. Yes.
Right.
And the personal allowance and all that.
Right. Thank you. Okay. Keith Hare, please introduce yourself.
Keith Hare, the CEO of the Virginia Healthcare Association, the Virginia Center for Assisted Living. This point may have been made, but I think it's worth reiterating if it hasn't, is that, we're talking a lot about nursing center level care, but these policies, also cover a larger gamut in the long-term care services spectrum. And while nursing center level care is a big portion of that, we want to forget that piece of it also.
Sure.
So,
Well, our policies are try to keep people out of your facility as long as possible and in their home.
and we agree with that policy.
You agree with that?
Yeah, we very much support it.
Okay. Thank you very much for that context. Any other questions here? Thank you for presenting. You have summary comments? So we really enjoyed your testimony and you got a tough job.
Thank you, Mr. Chairman. And for all the questions that were posed to us that we weren't able to answer today, we will get those to the members of the Joint Subcommittee ASAP.
Terrific. Thank you.
Thank you.
Okay. Moving on to topic number 2. We have hopefully some good news from our director, Kevin Padgett, of our new Health Benefit Exchange. It's a new department at the SCC that we created a couple years ago and had a successful launch last year. And Kevin, please tell us how we're doing.
Well, good morning. So yes, my name is Kevin Patchen. I'm the director of the Health Benefit Exchange, and happy to provide that update. And the spoiler alert is that it's a success story. So in 2020, the Health Benefit Exchange was created as a division of the State Corporation Commission. Our first and most critical task was to accomplish a transition for Virginia to move away from using healthcare.gov as the primary enrollment source in the individual market to a full state-based marketplace. And we accomplished that in 2023 when we held our first open enrollment in Virginia as a state-based marketplace. And it's exciting to say that now when we're about 13 hours away from the start of our second open enrollment here in Virginia. I'd say the three most critical operational components of our exchange include providing an online health insurance marketplace and enrollment platform for consumers, providing a year-round customer service call center for those consumers, and supporting a statewide network of navigators who assist consumers in that enrollment process. The ideals that underpin the work that we do, many of which come directly from our statute, is to support the continuity of coverage and to work to reduce the number of uninsured in Virginia. We work to establish a marketplace that is transparent and that promotes competition and consumer choice. Let me talk for just a minute about how we're funded. So the Virginia Health Benefit Exchange is funded entirely through non-general funds. Those are generated in the form of carrier assessment fees for plans sold on the marketplace. For fiscal years 25 and 26, we have non-general appropriations in the amounts of 52 and 54 million respectively. I'm very excited to report that as of now, we are financially and operationally stable. So the appropriations provided a $40 million working capital advance. We drew down 20 million of that and are now in a position to begin repayment of that 20 million this fiscal year. Those funds are used primarily to support the operations of the exchange, to pay for our online marketplace and enrollment platform, our call center, support of the Navigator program in the form of grants, and a robust marketing, consumer outreach, and education program. All right, so I said that we operate an online insurance marketplace. We've named it Virginia's Insurance Marketplace. And as the name suggests, it is a marketplace where Virginia consumers can come and shop available qualified health and dental insurance plans provided by Virginia carriers, and then enroll in coverage with those plans. And when I say qualified, we're talking about health insurance and dental insurance plans that meet requirements of both federal and state law. The exchange, in collaboration with the Bureau of Insurance, certify that those plans meet all of those requirements. Some of those key requirements include the fact that those plans include the minimum essential health benefits, do not allow carriers to deny coverage based on pre-existing conditions, and the like. Our marketplace also allows consumers to determine their eligibility for federal financial assistance in the form of advanced premium tax credits and cost-sharing reductions. Consumers also receive a full Medicaid eligibility determination. All of this process can happen almost instantaneously for consumers. We also allow consumers the opportunity to come and shop anonymously. They can put in some very basic household and demographic information, see their eligibility for health plans, for financial assistance. They can shop and compare those plans, and then move into the application and enrollment process. When we talk about the individual market in Virginia, where our exchange and our marketplace lives, it's helpful to sort of look at the coverage landscape. Major providers of health coverage in Virginia include employer-sponsored health coverage, the big piece of the commercial market, and then other government assistance programs such as Medicare and Medicaid. Virginia consumers who are not eligible for Medicare or Medicaid and who either do not have employer-provided coverage or their employer-provided coverage is too expensive based on some federal law and regulations, those are consumers who are eligible to shop for and enroll in coverage on our marketplace. What that means is one of our really critical functions is to support, as I said earlier, the continuity of coverage. When we talk about continuity of coverage, we're talking about consumers who are experiencing changes in their health insurance needs. So think about individuals who have begun to earn enough money that they are no longer eligible for Medicaid. It's critically important to us that we provide an affordable, quality health insurance option for those consumers so that health insurance doesn't become a limiting factor in their continued financial progress and stability. We think about consumers, generally in the age range of 55 to 64 who are looking to make some career changes. Maybe it's a great opportunity to go into consulting or to start a business. Again, we don't want health insurance to be a factor that limits consumers' choice and limits those opportunities. The other area where we really focus our attention on these kinds of transitions are entrepreneurs of any age who are looking to establish a small business. We've heard some really positive stories from consumers in all these groups who've shared with us they wouldn't have been able to start their own business but for the plans that are available through the marketplace. consumers who would not have been able to sort of partially retire early, but for these marketplace plans. And it's a key area of focus for us in supporting those consumers during those transitions and making sure that they are able to stay covered with health insurance. In order to make all of this successful, some of our key stakeholders include our insurance carriers. We're very fortunate here in Virginia to have a very robust group of health insurance carriers who are providing plans on the marketplace. All of these carriers are certified by the Virginia Bureau of Insurance and licensed to sell insurance in Virginia, and all the plans are certified by the exchange as meeting the minimum requirements. I want to give a shout out to our carriers here in Virginia, both health and dental, because they have been remarkable partners as we've gone through this transition. And as I said, we couldn't be successful without them. Another key group of stakeholders for us are what we call our assisters. And as the name suggests, these are the organizations and individuals who provide direct assistance to consumers in the enrollment process. One of those groups that I'll talk a little bit about is our navigators. As I said before, we fund through a grant program, or partially fund through a grant program, the operations of Virginia statewide navigators. These organizations really focus their efforts on underserved communities, both urban and rural communities with unique and specific language needs, and they are often some of our best experts in helping consumers who are making that transition from Medicaid to commercial plans. Also, our private insurance agents. We are very excited about the participation of our agents in Virginia. I will say, as we were going through the transition last year, our agents were some of our more anxious stakeholders, and there were some questions about whether or not Virginia could continue to maintain healthy participation from our agent community, especially since we were not going to be incorporating a technology known as enhanced direct enrollment that the federal platform used. You can see by these numbers, we not only renewed over 3,000 agents, which was the vast majority of those who were participating on healthcare.gov. We have had over 1,400 new agents apply for accounts on the marketplace this year. That's a remarkable growth and a good sign of the health of our agent community. And also a shout out to them, because they've not only been great partners, but we really have leveraged their experiences to continue to learn how, as we move from transition into steady state operations, we can begin to improve and hopefully even innovate. All right, so I said a success story, so let's look at some of the metrics that I think really demonstrate how positive our transition has been. We started out and we re-enrolled 343,000 consumers. These are the consumers who were, as of the time of our transition last October, enrolled in plans on healthcare.gov. In addition, during open enrollment, we added 57,000 new consumers for about a 14% growth of enrollment. Many of our stakeholders had set the bar for our transition at maintaining prior enrollment gains. So we were very excited to see that we were not only able to maintain those prior gains, but continue the trend of growth in Virginia. And when we talk about 343,000 and 57,000, it's important to remember these are individuals who are maintaining health insurance, which is critical for the quality of life for many of us here in Virginia. You can see a relatively high number of consumers are eligible for federal assistance in the form of advanced premium tax credits and cost sharings. This goes a long way to make the health insurance offerings on the marketplace affordable. Our average cost of an insurance plan for an individual was about $500. And so we see here that for a household, after the financial assistance programs, the average was around $108, $109 per month. And that is certainly part of what is driving the continued stability and growth, I think, of our marketplace. Our call center stays fairly busy, even in the off periods, fielding a little over 100,000 calls each quarter, closer to 200,000 during open enrollment, and we've been able to maintain wait times of less than 1 minute throughout all of that periods to make sure that consumers can get the help they need when they need it. So I've talked a little bit about some of our key stakeholders. We say that Virginia's insurance marketplace is by Virginia for Virginians. And while I like the sound of it, it is also an ideal that we very much internalize in the exchange. And you can see here a list of just some of the stakeholders that we work with on a regular basis and some of the methods that we use to engage with those stakeholders. We will not be successful in creating a uniquely Virginia marketplace without their participation and engagement. And we're very excited about the willingness and the level of participation from our stakeholders. It's my expectation if I come back next year to talk to you, that list will be even significantly longer than it is now. Another critical part of our outreach and education is our marketing program. Now I'll pause here and say that we participate very frequently in-person events, with consumer groups. We have a number of our staff who attend these events and really work at the grassroots level to get the word out of who we are and what we offer. In addition to that, we try and cast a wide marketing net. If we're going to succeed in reducing the number of uninsured individuals in Virginia, it's going to have to be through letting people know who we are and how they can reach us and what the services that are available for them. So our marketing effort is data-driven, and it's based very much on what we know about Virginia consumers. We started the process with some very detailed research to understand who our consumers are, where they live, what challenges they face, and then we continue to develop and hone that as we learn more about our consumers over time. You can see we focus on a large or a wide array of media channels to reach these consumers, and based on enrollment trends that we see in our marketplace as well as data from other sources, we've selected a few areas to really focus on this year. One that we're excited about is our outreach efforts for younger consumers between the ages of 18 and 34, and we're even reaching into platforms like Twitch to try and reach gamers, and we think this is really going to be an opportunity for some success and growth this year. Provided a few examples of ads that we will be running. We try to keep our message focused on really core principles: quality, affordability, and the need for health coverage, that it's there when consumers need it. A couple of updates that have been key for last year and the upcoming year. You all may have heard something over the last year or so about the continuous coverage or Medicaid unwind. One of the things that we've done to support DMAS and Virginia consumers in that regard is creating a special enrollment period that will maximize the flexibility for individuals who lose Medicaid to come and find a plan on the marketplace. One of the things that we've learned is that many of these consumers don't know that they have lost Medicaid until they go to the doctor. So we want to maximize the time periods and the flexibility for those individuals to receive coverage. Right now, that special enrollment period is set to end at the end of December, but we're working closely with DMAS, and as the tail end of their unwinding efforts continue, we'll make sure that our special enrollment period matches that. Lastly, we are in the midst of rolling out a program that's called Easy Enroll. This is a statutory program. Many of you may have seen on your Virginia state tax return, there's a box that you can check that says, I want to learn more about Medicaid. that's now going to say, I want to learn more about Medicaid, or I want to learn more about health insurance through the health benefit exchange. Consumers, taxpayers will then be able to fill out a schedule selecting what information they want to share with us. We'll take that information, build them an account, create a special enrollment period, and they'll be able to come directly to the marketplace and begin shopping for plans and coverage. A couple of other states have implemented similar programs in a similar fashion and have seen very positive results. So I want to give a shout out to the Department of Tax for their collaboration as we've gone through this process, and we're, again, looking forward to what that looks like in the future. As I conclude, I just want to express what a privilege it is to serve in Virginia's Health Benefit Exchange. We have a really wonderful team of professionals in Virginia who are dedicated to the mission of making sure Virginians who need coverage have access to it. And it's a service that we can see the immediate impact in the quality of life of citizens in Virginia, and very much looking forward to our future, and I'm happy to take any questions.
I've got a couple questions to start out with, Mr. Padgett. What is Virginia's uninsured rate now, and how do we compare?
So the last information we have is published by the Virginia Healthcare Foundation. It's about a year or two old, based on census data, and we're right around 7% is my recollection. I think there are a few states who have managed to get all the way to around 3%, but overall I think we're around 7% in Virginia.
And the follow-up on that is that have you seen it improve because of the new exchange?
It's a little too early to tell. One of the challenges we have is just the data collection and the timing of the data. It'll be, unfortunately, probably another year or two before we begin to see the impact of our transition.
And you have an impressive number of carriers that have participating in this. How does that compare to other states, especially states maybe our size?
It actually compares very well. There are I think we were the 19th state to transition to a state-based marketplace. And we have one of the largest carrier populations. I can't remember exactly, but I'm fairly confident we are at least in the top 3.
Terrific. That's terrific news. Any questions? Senator Deeds.
In Charlottesville, there was only one carrier, and so we hit the bottom in terms the cost of premiums were incredibly high. How do you manage to get so many carriers involved in this exchange?
Yeah, and I neglected to mention earlier, we now in Virginia are in a place where we have at least 2 carriers providing coverage in every county in Virginia. Some it's more like 10, but it's at least 2 in every county, and that's critically important for things like competition, consumer choice. I think there have been a number of market stabilization efforts that the General Assembly and the Bureau of Insurance have undertaken in the last few years, and I think we're seeing the fruits of those.
Mr. Chair, one more. Just have you done a deep dive on the 7% that don't have insurance? Is there any explainer or any simple way to understand why people still don't have insurance, 7%?
I wouldn't say there are simple or at least not obvious explanations. We do know that our younger, healthier population continues to not recognize the need for insurance coverage, and I think part of the challenge really is just getting the message, letting people understand what's available to them. Health insurance unfortunately, it isn't easy. So one of the things we're really focused on is how do we make this understandable, accessible for consumers, and we're excited to see what impact that has.
Senator Deeds.
I would just be interested in doing a deep dive on figuring out how many people are invincible, how many people still feel like cost is a barrier for insurance, and what we understand about why people don't have insurance. I don't know if those numbers can be developed or found somewhere, but I'd like to see them.
Okay. I will see what I can pull together, and we'll share what we have.
Okay, anybody else have questions? Senator Favola.
Thank you, Mr. Chairman. I think a few years ago, I want to say it was 2021, I think the General Assembly passed legislation that actually required on income, on the state income tax notices, I guess, if you will, that there be some information on whether or not the individual would like information on the health exchange, or how effective has that been? Because I remember I thought that was a great initiative. I worked with George Barker on it. Has it been great? Have we gained anything from that?
We will know next year. So this, the 2024 Virginia tax returns, this will be the first year that information's on those tax forms. So the statute had a.
Mr. Chairman, I would hope you could report back to us, because I think that effort might reach a lot of people who could be oblivious to the ads. And one other comment, Mr. Chairman?
Go ahead, and then I got to turn to the other senator from Arlington.
Oh, sure. I would just suggest if our younger people are the ones who seem to be part of that hardcore 7% uninsured, I would get, rappers and others to deliver the message, or find folks who the younger generation really relate to on your marketing strategy. Just my 2 cents.
Okay.
Well, and it's interesting because for the first time this year, we are actually working to engage some what are called influencers to do just that.
Senator Eben.
Thank you, Mr. Chairman. Thanks for the presentation, Mr. Patchett. I did have a question about, you said something that piqued my interest, which was that some of the people who are unenrolled from Medicaid found out for the first time when they went to the doctor. And I was wondering, are you aware what the outreach was to people who were leaving Medicaid?
Yeah, so DMAS could give you a much fuller explanation as to what they did. We know that they used a number of channels to send out notices. We provided them information about the marketplace that they could send with their information to consumers to try to make that handoff. I do know that one of the challenges with that population is there's a little more geographic movement, and so it's hard to keep up with people's contact information.
Are you okay? Yeah. Okay, good. Well, thank you very much. A lot of good news today,
All right.
which we expected. We've been reading somewhat about this in the newspaper, and congratulations for all the people who has helped. It's numerous, hundreds of people have made this success happen. Okay.
Thank you.
Thank you.
Next, we're going to hear from Alika Gorel. I think she's online. She's the. Yeah, you need to unmute, Ms. Gorel. I can barely hear you. Yes, ma'am.
How about now?
Okay, and we need to see you too if we can.
I have my video on.
Okay.
Let's see. I'll try restarting that. Is that any better?
Okay, I think you're fine. Go ahead.
Thank you, Senator Dietz, and thank you all for your time and consideration here. Just go ahead and share my screen. Just to introduce myself, my name is Alika Gurel. I'm our Director of Government Affairs here at Health Sherpa. We are the largest private channel for ACA enrollment. We enrolled about 7 million people nationwide in the past year and in the past open enrollment period. And I'm really pleased to be here today to talk a little bit about enhanced direct enrollment and what it is and how it can support getting more Virginians covered. I think you folks have paper copies of our presentation, but is that showing up for you folks?
Yes, we are getting that.
Wonderful. Great. Well, I'll go ahead and dive right in. So as you know, back in 2013, when the Affordable Care Act Marketplace was launched, initially all applications had to be done through the healthcare.gov core website. So regardless of whether you were an agent or a consumer, you had to go to healthcare.gov and submit your application there. Back in 2018, healthcare.gov opened up a new program called Enhanced Direct Enrollment, or EDE, which essentially allows third-party companies like us at Health Sherpa and 11 others to plug right into healthcare.gov's core technical infrastructure and provide a better user experience. So it's very similar to TurboTax and how they plug into the IRS. For clarity, I'll just say up front that EDE entities like Health Sherpa and those 11 others are not state vendors. They do not hold state contracts. They're simply, once that technology is built by the core exchange, they are audited and given permission to integrate and provide that technology to Virginians in this case. So again, important to note that Virginia had this capability from 2018 up until the state marketplace transition in 2023 and lost it during that process. So since 2018, EDE has rapidly grown to be the single largest channel for healthcare.gov enrollment. Most consumers on the Affordable Care Act marketplaces enroll with a broker. And the reason that EDE has become successful is that it empowers brokers to run an efficient business, helping people get covered in ACA insurance, that Affordable Care Act insurance. Brokers are very, very good at finding people who need coverage, serving as a no-cost marketing and outreach channel for the state. And what we've seen is that they're particularly good at reaching those underserved communities. Director Patchett just mentioned that there are that 7% uninsured and those young folks. What we found is brokers are really in the community helping communicate the value of coverage, again, serving as an additional marketing and outreach channel. We do see in particular that brokers are very good at reaching folks who are in the lower income household band. We see that about 2/3 of people enrolling through brokers using EDE are making under 150% of the federal poverty level, and they're disproportionately new to market, those individuals who didn't have coverage before and are getting it for the first time. So that's been a positive trend as well. And the way that EDE platforms help brokers become more efficient is by designing what we call a power user experience, technology that is geared towards a broker who is trying to help 200 people or more efficiently get through the enrollment process in a very short space of time. Whereas exchanges tend to focus rightly on the needs of an individual consumer who is enrolling themselves, may need a lot of hand-holding and support through that process. So just to give you an example, EDE entities tend to offer functionality that allows agents to very closely track where their clients are in that enrollment process, identify who might need support with some part of that or with post-enrollment document submission, all of those things that are needed in order to not just enroll, but use your coverage throughout the year. EDEs also offer bulk communication tools that allow agents who work within a large agency, who employ many agents, to manage that book of business. And all these might sound like individually small things, but again, when you're trying to help on the order of hundreds of people get through in a very short space of time, those efficiencies really matter. So again, the goal is very much, Director Patchett mentioned that Virginia has a large and healthy agent and broker community. The goal is to take those same folks who are already serving Virginians and make them, give them the efficiencies and tools to get even more Virginians covered. We have seen that other state exchanges are starting to pursue EDE technology. In fact, tomorrow, Georgia is going to launch as the first state-based exchange fully integrated with EDE. And they are going live with Get Insured, who is also Virginia's state exchange vendor. We've been having we've worked very closely with them on that Georgia transition, and very excited to see that work pay off from tomorrow. We'll certainly keep you folks posted on how that goes. We have seen also that Kentucky is launching a limited integration. They've launched a limited integration in 2022, continuing to build out that full EDE support. More recently, Illinois and New Mexico requested information about EDE as part of their RFPs for new exchange vendors, and the Michigan Senate included EDE as a mandatory part of their state exchange bill that passed the Michigan Senate earlier this year. So if there's anything we would hope that you folks sort of take away today, is that there is the Virginia transition, as Director Patchett noted, has been a very successful transition and has had a great first year. And there's still more opportunity to help even more Virginians get covered by leveraging that broker community, helping more of those new to market people, those remaining uninsured, bringing them into the exchange as well, and really using the broker community to extend the reach of the exchange. That is all we have today. Again, I want to note that we've had some great conversations with Director Patchett and his team over at the State Exchange. Very much looking forward to continuing those conversations, and again, appreciate your time and consideration today.
Senator Deeds has a question.
Yes, ma'am. I'd be curious, what strategies you would utilize to bring the rate of uninsured in Virginia down below to the national average, at least to 2 or 3%, and how you would do that, and what you think you could, what it would cost us to employ services like what you offer to do that.
Absolutely, and I'll take the first, in response, Mr. Chair, to the question, I'll take the first question first. In terms of how brokers reach individuals who are uninsured, we do see that essentially, we have this broker community in Virginia today. The goal is to help them reach even more people. And the way that brokers reach folks is that they often are actually coming from and are based in the communities that they serve. So all of those outreach efforts that Director Patchett noted that the exchange is doing, brokers do very similar work. They're popping up in grocery stores, creating a table in a church parking lot to get folks enrolled, driving a bus around rural areas. I like to say that with 5,000 brokers, you have 5,000 shots on goal for figuring out a strategy that works to reach people. Brokers are very creative. And again, we have seen that play out, not just on the federal exchange, but that's typical in other state exchanges as well, that the broker assisted community tends to be lower income, tends to be newer to market, and more underserved, and is better reached by some of these broker strategies as an enhancement to the marketing and outreach that the exchange does. In terms of cost, the good news is that, again, Georgia is launching this technology with the same IT vendor that the Virginia Exchange currently uses. So that technology has been built, and our understanding is that the technical implementation costs are not very significant. As a result of that, we've had some great conversations with Get Insured, the state's IT vendor, about that. There is certainly a small cost in ongoing oversight. In our experience, that hasn't been significant, and moreover, it's outweighed or offset by the additional exchange fees, so the percentage of premium paid by carriers to the exchange, that these additional enrollments that come in through the ED channel. All of those are certainly subject to that exchange fee as well.
Thank you, Ms. Guerrero. Are there questions from the members? Okay, thank you very much. Really appreciate your time and input. And I guess moving to our last panel, we have two folks here to report on HB 888 and SB 176, a work group to review and develop alternative services and placements for individuals with neurocognitive disorders or neurodevelopmental disabilities in lieu of the state psychiatric hospital placement. In other words, a brain injury waiver would be in this topic, right? And we have Leah Mills here, who's the Deputy Secretary of HHR.
Mr. Chair,
Yes.
what you're talking about brain injury waivers, as well as, it seems to me, what we found in psychiatric hospitals, you've got people that just don't belong there, people with autism and people that are not just, they're old and forgetful, but they don't have psychiatric illnesses. And that's what the gist of this is, trying to figure out what to do with those populations.
Right. And,
I think.
And we have Virginians that we pay $350 a day to stay in the facility in Massachusetts right now. I don't know if I'm sorry, I shouldn't have started the commentary, but why don't you get us back on track here?
No, thank you, Mr. Chair. So am I okay on time? I hope you all are.
Yeah.
Okay, perfect. Okay, so thank you all so much for having me to talk about this very important topic to support Virginians, as you all noted, with very critical needs. My name is Leah Mills. I'm one of the Deputy Secretaries of Health and Human Resources. I'm out here on behalf of my Secretary Janet Kelly. So thank you very much for having me here today to talk about this. I'm going to provide an overview of a report on this HB 888, Senate Bill 176, to review and develop alternative services and placements for individuals with neurocognitive disorders and neurodevelopmental disabilities. So I'm going to go ahead and skip, and I'm so sorry, I should have had this earlier on in my presentation, because I think that everyone here probably knows this, but I just want to make sure that we all do, to make sure, just give us some level setting, if we will, about who we are actually talking about. And I think that Senator Deeds and Delegate Sickles, you really kind of hit the nail on the head, if you will, because we're talking about individuals, but they are very different. And it's a really complex topic. And I will say that this work group, and I'm just so very happy that Senator Favola was able to join in on pretty much all of our meetings. It was a really complex topic. But we're dealing with two different subsets here: individuals with neurocognitive disorders and neurodevelopmental disabilities. And they many times they develop across different portions of the lifespan. So we're talking neurocognitive disorders are they can develop due to medical causes, and typically we talk about maybe those with dementia, but it's also encompassing individuals with brain injury, trauma, stroke, and maybe those can happen at any time, and also individuals with neurodevelopmental disabilities. And those typically occur earlier, they happen in childhood, and they're diagnosed in childhood. And these are defined per the American Psychiatric Association and the DSM-5 in their manual. And what we learned in our work group, and it's also noted in the DSM-5, is that these individuals typically can are medically complex many times, and also have accompanying psychiatric conditions as well. So very, very complex. I do want to say, as we're talking through this today, I know we're talking about diagnoses, but throughout our work group. These are individuals, and we're talking about their diagnoses, but they have unique abilities and challenges and strengths and capabilities. And so just want to keep that in mind because we are talking about the individual that just happens.
If you don't mind, and
Yes,
you're
sir.
telling us that because a lot of times people lump people in a category that they
Yes,
shouldn't
well,
be
yes,
lumped
sir. And then
into?
and this particularly so because we have two different,
Understand.
Yes.
Understand,
So-
well, we don't want to do that. Nobody up here wants to do that.
No, sir, and then I know that
Okay.
we're being live streamed, and then I
Okay.
think that
Thank you.
our work group, that was something very important to the members on our
Okay,
work
terrific.
group. So thank you, sir. Thank you for letting me handle that. So let me go backwards here. So as you all will know, this work group originated, I think, or was informed rather by the JLARC study last year, which they conducted a very intensive study of our state psychiatric hospitals. And one of the findings was that 10% of those that were discharged had the diagnoses that I just mentioned. However, they had longer lengths of stay. And I think that when JLARC staff did their interviews, it was reported that concerns about the appropriateness of the placement and how these individuals were receiving care and whether it was appropriate placement. And so very much that Senator Favola's bill and Delegate Watt's bill was informed by the JLARC study. And so very briefly, the legislation which passed is not only the work group that we're going to touch upon some of the findings and recommendations here, but it also specified that for purposes of civil commitments and TDOs, that the behaviors manifesting from the neurocognitive disorder and neurodevelopmental disabilities would be excluded from the definition of mental illness. And it also stipulates that state facilities may require a reevaluation of persons' eligibility for TDO if there's reason to believe that the symptoms are solely from the neurocognitive disorder or neurodevelopmental disorder. There is also a reenactment clause in this legislation. And in the second enactment clause was the work group, which directed the Secretary of Health and Human Resources to evaluate the placements for individuals with neurocognitive and neurodevelopmental disorders. And we were to look at the current landscape of placements, develop services and placements that would be an alternative to state psychiatric hospitals, identify funding and statutory changes needed to prevent inappropriate placements, and recommend training for magistrates and CSBs related to the implementation of the Act. And issue a report by November 1, which I will tell you a little bit more about that here in a minute, because I think we're well on our way. So let me talk to you all a little bit about the work group process. Because of the complexity of this issue and having the two different neurocognitive disorder, neurodevelopmental disability group, we felt that we really needed to make sure that we had broad representation on the work group. So we had over 40 individuals represented on the work group. We had 5 work group meetings over the course of the summer into the fall. And at the top there in the blue kind of highlights the agenda, if you will, at each work group meeting, because we heard from each of the stakeholder groups. And we had information, like we had perspectives from the provider community. We heard from our state agencies so we could learn more about the services and the supports that might be available. But we also wanted to hear perspectives from families and advocates to hear maybe things that were needed, where things went wrong, which we heard about that, and also where things maybe could have gone right. We also heard from law enforcement, which was incredibly helpful, and we heard from the magistrates as well. So with that being said, we had a very, very heavy charge, and we took it quite seriously. And I do want to thank Senator Favola, because I think she came to every meeting, as did Delegate Watts, and Natalie, the Executive Director for the Behavioral Health Commission, also joined. So I think that really helped a lot. If nothing else, I think that what the work group accomplished is we had a thorough understanding of the needs and the gaps in all of the services. And I think that everyone got a better understanding about each other's perspective and things that we could do better with the existing system. So I think that was a huge accomplishment in and of itself. So let's see. So I'm going to very quickly go into just a couple of the slides that we, from the presentations that we had over the course of the work group meetings. So this was one that we received early on, and I think that, and it may be one that you all have seen before, because I think it highlights the 10% that are discharged, or the 10%, the low number of individuals served in our state facilities. This is purely for individuals with intellectual disability and developmental disabilities, and you will see that there is a low number being served, and it's really declined throughout the years, and I think it really reflects the commitment and the investment made to the community and to waivers. But even still, we really need to do more to really support families and communities with providing services to this to these individuals and their family members.
Yeah, I want to make sure I understand this graph. What you're saying is basically we used to I guess admit a whole lot more developmentally disabled people than we do now, but we still admit too many. We just don't admit nearly as many as we used to.
Yes, sir.
Okay.
So we have 189 right now.
Yes, sir. Well, this was, let me see, this is FY 24.
Okay. So those are theoretically 189 beds we could use in the community for other psychiatric disabilities. And okay. Our challenge is to get people in the right situations everywhere. Okay. And we got 189 opportunities here.
So, and Delegate Sickles, I was the convener on behalf of Secretary Kelly. So if you all have more technical questions, I do have agency staff here.
Okay.
So
okay.
if I am incorrect, please stand up. Okay.
Thanks.
So.
Thanks. Appreciate it. Senator Fuller, did you have a question? No. Okay. Okay. Very good. Thank you. This is very interesting.
So just again, highlighting some of the slides and from some of the presentations over the course of the work group. So this is covering, we were tasked with reviewing some of the services and alternative placement opportunities, and this is highlighting opportunities for individuals with neurocognitive disorders. So what you have here is integration of behavioral health into existing settings. And so these are we heard about five services and that serve geriatric dementia population that are successful, that are already funded. And so you will see that they provide integrated behavioral health care models. They're across the Commonwealth. They have been effective at reducing rehospitalization for individuals with neurocognitive disorders, and you can see that the rate is 3%. There are some procedural challenges with these programs, with having the timing with the ECO TDO process, and the individuals must volunteer to participate, but they've had success. I think that some of the themes with these services are the support they provide to caregivers, respite care to caregivers, training for nursing home staff for those that are embedded in long-term care facilities, care coordination between the referring entity, or allowing individuals to remain in their home for the community-based models. And this is just a highlight. When you all get the final report, you'll get additional information about these. So moving on to, we received during one of our meetings, this is a program that we received information on that provides services to youth with autism, so covering the neurodevelopmental side of our study, of our work group. So this is the Kennedy Krieger Institute located at Johns Hopkins. We had one of their experts come and spend quite a bit of time with us talking about their program, and it was just fascinating because it encompasses inpatient, outpatient, and intensive outpatient services for youth and young adults with autism. And you can see some of the services that they provide. And this is something Virginia does not have currently, but they also have a community consultation and education component, as long with those 3 levels of care. And diagnostic treatment. And I think that it just was something that our work group found very, very informative. One of the things that we do know is that some of our youth also are being served out of state.
Ms. Mills, could you state again what Virginia doesn't have? You said that we don't have right now. Is it the whole pyramid or the top?
There are portions of this that we do not have.
Sure.
And yes,
Okay.
it's more of the, I think, the intensive outpatient.
Okay, terrific. Thank you.
Okay, so I'm going to walk you all through some of the work group recommendations, and I will tell you, Mr. Chairman, that because we had 5 work group meetings, and we were trying to solicit public comment, and we had over 40 members. Our last meeting was on October 11th, and we just received feedback last week. So these are a little more not as specific as far as like the funding, but you will be getting more details next week probably. But we have 17 recommendations at this time. We wanted to make sure that we incorporated everyone on the work group's feedback as best we could, because it was a very voluminous study and effort, but we took it very seriously. But I'm going to walk you through the themes and then be happy to answer any questions and provide more details as we can. So I think that, let me give you some of the common key themes here. Oh, and as an aside, again, I'm speaking on behalf of the work group as the convener. We understand there may be some folks that they may have some, they may not be in full, complete agreement with some of these. I think that we did our very best to try to solicit consensus. So just want to make sure that that is known and just putting that out there as well. So just wanted to convey that we're just trying to do our best we're going to acknowledge the consensus or those that do not agree, and we'll incorporate everything into a report for you all to see. So let's see, the main themes were integrating behavioral health services into existing inpatient settings, making sure we're appropriately meeting the needs of the individuals, better communicating information was sharing, as well as better caregiver support. That was a recurring theme. I will say a comment that I think I wanted to share with you, because we had the benefit of hearing from our family members and stakeholders, is that families are overwhelmed. And I don't think I'm overspeaking when I say they're terrified of the process. And people told us they don't always feel like they fit in and they don't know what to do. So we really tried to acknowledge what we heard and come up with some recommendations to address those concerns. With this first finding, which you can see, and I know there are a lot of words, this is addressing the reenactment clause that was included in the legislation. So what we looked at is that there are limited alternatives outside of the state for individuals with neurocognitive disorders and neurodevelopmental disabilities. The landscape of services, even though we are building them out as quickly as we can in the Commonwealth with build out of the crisis services, there are still some unmet needs, particularly for individuals with neurodevelopmental and neurocognitive disorders. It is going very, very quickly and doing a great, great job, but we just need to maybe connect what we have already. So that is already in
Very good.
place.
Senator Deeds has a question.
And I appreciate your work and your recognition that families are desperate and they don't feel like they fit. By not reenacting and not coming up with a recommendation for how you deal with people with cognitive disorders, with neurodevelopmental disabilities, you're basically saying that even though they're not well treated in psychiatric hospitals, that's the best we can do?
No, sir. They are saying that they would like to have more information about what is available. And so they feel, which we will get to with the caregiver recommendations that are coming along. So I think that we heard from the magistrates that the evaluation of evidence, let me continue if maybe I can better
Yeah,
explain.
please continue. I
Yes.
mean, if this was easy, we would have solved this problem many years
Yes,
ago.
I'm very sorry. It's really complex because
We're
I think
listening.
it's, magistrates had said that they feel that during the short time frame that their job is to evaluate evidence presented to them and apply the law in evidence. And a primary challenge is obtaining sufficient evidence to determine whether the symptoms or behaviors are exclusively caused by the neurocognitive or developmental conditions. And so the concern raised, if legislation is reenacted, they would not be able to determine whether there's probable cause to believe that the behavior is solely a manifestation. It would be very challenging for them to make. There's no clear right answer, and so they would not be able to issue TDOs at all, particularly under an 8-hour time limit. So that is their concern. If they're at the point where they have to make this determination with probable cause, with the criteria, and they're not clinicians, there would be people that may not be able to receive services.
Okay. Senator Deeds, you?
Now, I would just anticipate that we'd have a bill to move the TDO period to 24 hours or something, then we'd have plenty of time. Would you agree with that?
That is a policy decision, sir. I cannot, as I said, I was the convener of the work group.
Well, let's talk to the magistrates about that.
So I think that it is a very complex issue, and I think that we had a work group convened of volunteers.
Sure. No, we really appreciate all the work you've done. Senator Favola?
I will just say, thank you, Mr. Chairman. I do give you a great deal of credit. It was a very large work group, and we learned a lot. There are many aspects to this problem, unfortunately, but at the end of the day, I think we have to strengthen the recommendations regarding a pathway forward. And maybe that's something the General Assembly can do, but, we need to perhaps ask for Medicaid waiver so we can fund other sites to serve our folks with autism or other neurocognitive, developmental, or like issues, because we just can't continue the way we are.
Thank you, Senator.
So that's something that I guess
So we're going to try right
we'll work on
now
that.
not to ask you any questions till you finish. This is really good, so let's all listen hard now. Okay.
No, that's okay, that is. So I think that when you're convening a work group and you have the breadth of the topic and you're trying to provide information on behalf of a work group and provide you all with tangible policy options, we're trying to make sure that you have all the information that you need. So I do think that it was, when you're receiving feedback on everything, I will move along. I do think that you will see that there's some additional information. And finally, the charge was to look at alternative placements. So, and we were asked to provide, I think that the large consensus of the work group, with a couple of exceptions, but I think I can honestly say almost everyone, they were commending the intent of the legislation, but had concerns because they felt that the reenactment could potentially have an unintended consequence. So I think that would be the best way to word that. So I think that Right Help right now has just, there's been $1.4 billion invested into the system. Crisis is built out, but there has been just maybe some more supports provided, and connecting of the dots was the findings from the work group. So moving on to the next recommendation. So building out sustainable and comprehensive continuum of care. So individuals in crisis should be served in communities where they reside. There are major gaps in the current available service array. There are successful programs administered through the department, which we went through already, that have huge success. And so these 3 recommendations here reflect building sustainable and comprehensive continuum of care. So those are what we had recommended here. About the first one is actually addressing the brain injury recommendation. So we had heard from at one of our meetings about the need for a brain injury waiver. And so that is recommendation number 1. Embedded in that is looking at other services that might accompany that and having, maybe some variation with that recommendation. The second one is looking at the other need for continuum of home and community-based supports, again, building on those existing services. And lastly, looking at, again, another existing program, which is the discharge assistance program. Okay, so my apologies, and that is on this slide right here. So the next set of recommendations are enhancements to our crisis services. So with the REACH program, we have, there are efforts in place to make sure that information is shared with the community. REACH is the Regional Education Assessment Crisis Services Habitation Program. And this is a program that was established to provide statewide crisis system that serves individuals diagnosed with developmental disabilities who reside in Virginia. They provide core crisis, mobile crisis response, community-based stabilization, crisis therapeutic homes to adults and youth. And so there were recommendations made to bolster communication about availability of these services, which are already in place. But what we learned is that people in the community don't know what's happening. And so to make sure that we talk about what is going on currently. And so the next recommendation is from the work group is to build on the capacity and competency of the CRCs and the residential crisis stabilization units. And while there's cross-training is already in place that to support the efforts that are going on with supporting neurodevelopmental and neurocognitive, serving the individuals with neurocognitive and neurodevelopmental disorders. Okay, so again, this recommendation is pertaining to enhancing existing community inpatient settings. So what we learned during the work group meetings is that individuals whose sole behaviors are a manifestation of their neurodevelopmental or neurocognitive disorders, they still may be a significant danger to themselves or to others, and they still may require high-intensity behavioral health services. That also was a recurring theme. And they also still may require inpatient care. The other finding that we wanted to share is that nearly all the private inpatient facilities in the state have those disorders as exclusionary criteria for admission. And that is maybe due to the lack of appropriate environmental or clinical services to meet their needs. And I think you may be hearing about that after I am done from the next speaker. So those were huge concerns as well, which goes back to the first finding and recommendation. So that was one of the reasons why for the first recommendation as well. So to address that concern, the recommendations here were we really need to continue to expand on the capability of the private facilities to be able to serve more individuals with behavioral challenges who may need inpatient care, and to continue to support and build capacity among community providers to provide crisis intervention and to help them when they're referred to crisis services after stabilization through the expansion of these integrated behavioral health services like the ones that we talked about for the geriatric and dementia population. Okay, so the enhancements to the existing community inpatient settings. So Individuals lack services and clinicians with the specialization required to meet their needs, and existing providers cannot always access expert consultations to support individuals in the least restrictive environment. And so this is the best-in-class treatment and rehabilitation center for individuals with neurodevelopmental disabilities. And so this is the one that addresses the Kennedy Krieger, what we learned about Kennedy Krieger.
Sorry. Remedial help here. Tell me about the Kennedy Krieger, and is that too long?
Yes, so that was, Heather, would you like to come up?
So you developed a policy here.
It was not on a specific provider, but on the type of services they provided.
Heather, you want to introduce yourself?
Good morning, Heather Norton, Deputy Commissioner of Community Services at the Department of Behavioral Health and Developmental Services. The Kennedy Krieger Institute is a specialized program for individuals with neurodevelopmental disabilities. They primarily work with children, but also have a program both of outpatient and an intensive outpatient for adults. And then their inpatient is focused on their children, but they focus specifically on individuals with neurodevelopmental needs.
Where is it?
It's located in Maryland.
Okay. And she mentioned that there was some kind of, your work group decided to do something, or there was an outcome of some kind?
We discussed, we actually had the director of the program do a presentation on their program, and one of the recommendations is to look at developing a neurodevelopmental unit here in Virginia that is based on the best practice of the Kennedy Krieger Institute.
Okay. With indulgence of the committee here, last year we heard we're not doing a very good job on discharge planning, and there's a psychiatric hospital in Hillsville that they were letting people out on the street. We heard that the community was upset because all of a sudden there's somebody they just let out the front door into their community. Is there something administration is doing to up your game with private facilities on discharge planning?
We are working collaboratively with all partners around discharge planning, and we have of course, for the state hospitals, the discharge assistant planning funding, but are also working, and I think one of the recommendations that Ms. Mills is going to talk about very shortly is around those communication barriers and things that were identified as part of the work group, and making sure that all team members are collaborated with prior to discharge so that the right supports and services can be put in place prior to an individual being discharged.
From a private facility?
From both private and state hospitals.
Well, I hope we're doing a better job at our hospitals.
We are.
Okay. All right, thank you. I'm sorry,
Thank
Ms.
you.
Mills. If you please continue.
So, no, thank you, Mr. Chairman. So, again, okay, so this finding is on the communication and information sharing. So we learned during our work group, again, about the importance of, we want to make sure we're supporting our caregivers, and communication barriers may be an issue that we could do a better job with making sure they have all the information. So this one is trying to tackle that, and so we are reviewing, this was recommendations on the right, are reviewing and enhancing requirements for policies and procedures for the involvement of families and caregivers throughout the crisis response and intervention process. And then below it is developing best practice protocols that define stakeholder roles and responsibilities, including sharing of clinical information for providing diversion services to those individuals who present in the emergency department. So there is a little bit more to that, but I think that may get a little bit at what you're getting at here. But I think the key is that knowing who has access to what information, but particularly with our partners, and knowing that is one of the key recommendations. So What we learned also is workforce capacity. The workforce needs ongoing support to develop skills, capacity, and competency for serving individuals with these diagnoses. And there is a lot of work going on to that effect, but these recommendations pertain not only to our state facilities, but to the private facilities as well. So this is to implement comprehensive training programs for staff at state and private hospitals, to make sure that they demonstrate competency in supporting individuals with neurodevelopmental disabilities and neurocognitive disorders. Develop a training curriculum for crisis response, which I believe that there's already cross-training in place, but ensuring that is bolstered and shared, and identify funding resources for provider development and training on assessment and effective treatment for individuals with neurocognitive or developmental disorders. Okay, and Mr. Chairman, I think that this is my last recommendation right now, but I do think it's one of the most important ones because it is pertaining to supporting caregivers. So what we heard is that the importance of caregivers and the role that they play in supporting individuals and ensuring that their wishes are met and fulfilled, and making sure they're served in the least restrictive setting and in the most appropriate setting, and advocating for their needs. And so the recommendations on the right are seeing if we can identify appropriate funding mechanisms to support expanding access to respite care providers. Many individuals maybe just need a break, and so there are some individuals that are 100% caregivers for their loved ones, so maybe we could identify some other ways to provide them some respite. Reviewing and strengthening policies to ensure family members and caregivers have multiple options for visitation. There was legislation passed last year, obviously, to ensure that when somebody was in crisis, that individuals were in crisis, that they could have their family care or caregivers with them in the emergency room, but ensuring that information is communicated with all providers to make sure that family members knew. We heard stories from individuals with family members with dementia that said that they knew that they could be a calming influence on their loved one if they just had access to their loved one. And identifying and implementing strategies to simplify the process of creating psychiatric advance directives. Said that might be a way to help build infrastructure to ensure providers can access these directives and educate stakeholders on these and their benefits. So with that, sir, I will say that concludes my presentation. We are tasked with providing you all a more detailed report and summary of our work group activities, which we will be giving to you very soon. The only caveat I was going to just share with you all is that we received everything and refined them as of early this week. So we will be getting you those details with more specificity around the recommendations in the upcoming days. And with that being said, I'm happy to.
Thanks, Ms. Mills. Do we have a respite care network for this population, or you just really need to develop it from scratch? And is that right? I mean, you say we're expanding access to respite care providers, and we're talking about these disorders. Do we have a network now to expand?
So what I can tell you is that I know that Medicaid provides respite, and I know that DARS has a respite program. There are individuals that are full-time caregivers that perhaps DARS may be an opportunity. Because I do not think it's income-based, and that it's rather small, but it might be an opportunity to provide some support. But that, again, is something that the work group just kept coming up with, like if caregivers could have some support. And that is, again, a policy option and just conveying the work group findings.
Sure. Senator Favola, wrapping this up.
Thank you, Mr. Chairman. I will just say kudos to Leah and all those who participated in the task force. And Mr. Chairman, I think the task force is right. We're not ready to reenact the legislation the way we had drafted it, which was essentially diverting those with neurocognitive and neurodevelopmental disorders as the primary or solo diagnosis, completely diverting them from our psychiatric facilities because there's really not a network out there to divert them to. And so the task force reached that conclusion, I think, with due deliberation. My disappointment, and the General Assembly can take this on, is the task force really didn't lay out a pathway for us to create other alternatives to the psychiatric facilities. And that's really the task ahead of us. And there's some tools we can use, and you know,
There's still time.
there's still time, and you and I can have these conversations. So now it's with the General Assembly. Thank you.
Thank you.
You'll have to correct my pronunciation. And he's the president and CEO of Virginia Health Services, and he works closely with some friends of ours here. Kleizek or Klezek?
Kleizek.
Kleizek.
Perfect.
Welcome.
As I see with Delegate Kurzek, it's not too difficult.
No,
So you guys have practiced with it. So
He pronounces it Krezak, like it
Kurzek,
has an A
Kleizek,
in it.
Klitschek, could go either way.
Okay.
Awesome. Well, thank you. Yes, Mark Kleizek from Virginia Health Services. We primarily service or have nursing homes on the peninsula in Newport News, Gloucester, and Kilmarnock. And I'm also vice chair for the Virginia Healthcare Association and VCAL. So I just really wanted to thank you for letting me be here today, because while it's a challenging subject, I'm happy to be here in the spirit of collaboration and try to bring a little more awareness of what we're experiencing in the nursing home community. So as Deputy Secretary Mills mentioned, we're not just dealing with the elderly, we're also dealing with the young disabled, because the young disabled oftentimes will outlive their parents and still have their disabilities, and the nursing homes become a typical place for people to be discharged to. And so what we want to do is really strengthen the nursing homes and strengthen the process so that we can care for these individuals, because they do need care in the community, in the least restrictive parts of the community, so outside of acute care. So what I'm thinking is really necessary is a triad, which would be partnerships, payment, and a really expanded portfolio of services that we can offer these individuals that have these issues. We've successfully had pilot programs in 2 nursing homes in Virginia, and that happened through financial assistance from the CSBs, and that gave them capital. That gave them behavioral health specialists in the facilities, helped them with enhanced activity staff, training, and care coordination. So it really took care of the entire gamut of what we needed. And what we could envision is a health hub where the state hospitals could continue to own the patients and be the primary resource where they are helping the nursing homes and other care areas care for these individuals. But what we really need help with is regulations. We need help with building our physical plant, and we need help with the rates that the nursing homes are paid for these individuals. What happens with the rates is individuals that have developmental disabilities typically will lower the rates that nursing homes receive because they're not really clinically complex individuals. And most of the nursing home reimbursement is based on being clinically complex. So these individuals typically can dress themselves and take care of themselves and feed themselves and things like that. And that drops our Medicaid rate. So that makes these types of individuals and admissions not as attractive as just a typical Medicaid admission from someone that's coming from the hospital. So by having an add-on rate or some other rate to the component for caring for these individuals would make it much more attractive for more nursing homes to participate and want to really care for these individuals. We also need regular and scheduled visits from mental health professionals. This is not going to be something we can fix with telemedicine, just putting in a screen and a camera and hoping that a psychologist is going to help do intervention. So what we really need is embedded individuals with really great mental health backgrounds and training that can assist the nursing homes with this care. And also, we need a nice or good locations for mental health emergencies. So what happens in the nursing homes, unfortunately, is when there is a mental health emergency, the person is typically transferred to a general hospital, not always to a psychiatric hospital. And unfortunately, what happens there in the emergency department is that person is medicated. They sit on a stretcher for a number of hours, and it's a waiting game until the person has resolved their issue, and then they come back to the nursing home, typically with no recommendations on how to improve the care and how we can do a better job for those individuals. So it's just that the behaviors have subsided. So what we need is better places where we can have coordination and cooperation with mental health professionals to help de-escalate those issues, primarily or preferably right in the nursing home. That would be fantastic if there was a way to do that. If we can't do it in the nursing home, then having a location where we could have those people go to get actual really good care and come back to the nursing home with good recommendations and ways that we can improve care going forward for that individual. The other concern for us on the regulatory side is the typical behaviors that we want in a home-like environment don't mesh well with the regulations that we have in nursing homes. So we look at patients that have these behaviors, and oftentimes they will cause us immediate jeopardy citations. They'll cause us fines, even though the facility did everything they possibly could for the care of the patient. So we just need some regulatory reform so that we can have good regulations that can really acknowledge that the facility has done everything that they possibly could for these residents. They still had these behaviors, but that shouldn't be punitive. It should be, how do we move forward and help these individuals going
Mr.
forward?
Kreisig, can I ask you a question here? Kreisig, are you working with DBHTS on this? I mean, this should be, what you're saying is really legitimate concerns, and it could help the public, it could help the private sector. And why are we talking about this here? Why isn't the industry working with DBHTS? You can solve this without, well, you'll probably need our help, as you said,
Yes.
with the reimbursement rate. And I think there's a willingness in the General Assembly to do that. But it'd be great if you guys had a plan, work with the administration to figure out how to do this. And I'm sure they would agree with most of maybe everything you've already said.
So we have had conversations, and Keith, if you want to just talk about how we've started that.
We did at the request of the commissioner. We have had initial conversations about this. Again, I don't want to put words in their mouths, but I think they do agree that these are challenges and something that we can work toward. But we do need a comprehensive plan. So, and that does not currently exist.
Keith, can you get this done before January? That's when we work, January and February.
Sure. I do not think that we could get a comprehensive plan together by January. I definitely, think that we could put the framework together on how to look toward what a rate would be around this. And also, we have had providers, member providers, who've expressed an interest in collaborating with DBHDS on this. And so I'm going to give you a partial yes on that.
Well,
I just want
to encourage you all to work together. I mean, really put
absolutely.
your heads together and make some progress on this issue.
Yeah, absolutely.
Okay, thank you, sir.
Thank you.
No, I'd say the department's been very helpful. Keith asked for a meeting, and we had at least 6 members of the department meet with us for an initial meeting. So that I think we're going to start that path. And I think the last thing I just wanted to wrap up with is where we invest is where these individuals are going to reside. And so however we can find the funding and the least restrictive environment for these folks is exactly where they're going to reside. And we need to all feel good about what we're doing for our individuals in the community with these developmental disabilities. That's it.
Very good. Any questions? Yeah, Ms. Massart.
Just a quick question on, in terms of looking forward with a plan or where to go from here. We've got some of these regional programs out there. Do y'all have an idea of where where specifically the needs are if there was some kind of expansion in order to sort of meet the needs of this population. Like, where are they coming from? Where does it make sense to move the needle?
I think the short answer to that is not really, and that's part of the reason we need a comprehensive plan is we need to figure out regionally, and we need to all accept regionalization, we think, because we think it needs to be, from an efficiency perspective, we all know there are shortages of these types of professionals across the Commonwealth. And so if we're talking about doing this in a, we're really talking about two different things here. I just want to be clear. We're talking about, one thing is your typical nursing facility resident who's having behavioral health issues and needs a place for, you know, a mental health issue that has risen to the level of crisis. That's sort of the TDO conversation that I think the original bill kind of led to the work group. And then we're talking about the two pilot programs, or if you want to call them pilot programs, the two programs that are more of a step down or diversion type of program for the state hospital population. And in this case, you know, the regionalization of that is what I'm referring to. Those programs have succeeded because there was some initial investment in terms of some capital costs, but as far as financial investment, there's not. They're operating on Medicaid funds. How they're being helped is they're being helped from the staff being provided by the CSB. You know, the behavioral health staff being provided by the CSBs coming into the facilities, and those are dedicated units for the behavioral health population. And so to replicate that requires a great deal of planning, a great deal of coordination with the you know, whether it's the CSB or some other behavioral health professional staffs in a region to be efficient with those staff. And that may require some travel time, and because you can't do that in every nursing facility that might have interest in it. I mean, there's got to, we think anyway, at least in rural areas, that doesn't seem possible. Maybe that's possible in an urban area. We don't know. And that's part of the reason we think a comprehensive kind of planning process is really necessary to figure out how would you replicate that. Is it regional? Is it not regional in an urban area? And we just don't know the answer to that yet, because that coordination has to be there to get that staff resource provided. Now, the Medicaid side, you know, there's still a cost. That even those facilities that are doing those pilots are losing money relative to the quote normal, if you will, nursing facility population, and they have some ongoing costs. They have higher staffing ratios despite the lower acuity needs on the sort of typical nursing facility side. So this all has to be borne out. Then we've got the issue with availability of beds. You know, those pilot programs began during COVID, you know, and we had occupancy drops, so there were beds available. So we've got a lot of things to figure out because, you know, again, if you're going to do a unit, you might have to pool some beds together to do that under the current structure too. And so we've got a lot of little, and that's why, you know, Chairman Sickle, I mean, that's why we, you know, Keith hedged on a comprehensive plan by January. There's a lot of steps. It's all these obstacles we think are.
But you haven't started this yesterday. You've been working at this for a long time. I mean, you know, it's hard. All these things are hard, but
all these things are hard too because we don't know what the state will or won't do on the Medicaid side.
I'm telling you, you're gonna have a good partner here if you come up with a good plan. I'm promising you that.
Yeah, and this was all in the work group. I mean, we saw the draft of the report. We haven't seen the final, but you know, this has all been discussed there as well. And you know, we think all these obstacles can be overcome. I mean, you know, we're just saying these are all steps that sort of have to be figured out.
Sure.
To see if this is viable.
Well, you got all of November, all of December. Okay, Ms. Massart, do you have a follow-up?
No, sir.
Okay, Senator Deeds.
The only thing I'd say is it might make sense to look at those 189 people that are in those beds, find out where they're from, and find out what part of the states we have the greatest need in, and whether those are the parts of the state where it makes sense to develop the capacity.
That's pretty basic. Thank you so much.
I would say, though, I think what the speaker's saying is in addition to creating a unit with separate beds and the appropriate treatment for the population we're talking about, it would also be worthwhile investing in some community-based services in those regions that I think Senator Deeds was trying to get you to tickle out. So it should be multi-pronged, because to the degree we can serve somebody in a community-based setting, that would be our preference.
Okay. All right. Are there any other questions? And we are 31 minutes over time, and a lot of us have another meeting at 1. So maybe I'll see some of you on the first floor in a few minutes. And thanks for coming, and we'll see you next time. Appreciate it.
Senate of Virginia, Richmond, Virginia.